Good evening. Sorry to interrupt. Topic today is triple and quadruple agonists, the pharmacologic pinnacle of weight loss therapy. At the very outset, I have to thank Ashutosh sir and Pallavi ma'am for giving me this topic because it was quite a learning experience for me also. And we'll talk something about obesity. We can talk about the pharmacotherapy, how it has evolved, and then we will also talk about the current and emerging agonist therapies, which many of the speakers before have already addressed. And I will try to talk about the mechanisms, impact, and preservation strategies, clinical approaches, safety access, and future directions. Uh, so, as we know that obesity is a global challenge, and nearly 3 billion people worldwide are affected by obesity, and by 2030 it is projected that at least 50% of the world population will be affected by obesity. So we can understand that what a kind of the menace it is going to create. And now we recognize it as adiposity based chronic disease. The reason being that the complication can occur through multiple effects of adiposity and may have effect on more than one organ. And the various things we already know, that anxiety, stroke, dementia, OSA, everybody has talked about it. I think MSLD and multiple cancers like breast, cervical, pancreas, uterus, gastric, gallbladder, and all. So how are we going to benefit the population by weight loss? That is what we are going to talk. Why we need drugs for weight loss? So if we put the patient on weight loss therapy, sorry, many things I'm just going to speak, it's not there in the slide. So if the weight loss is 0 to 5%, the beneficial effect will be seen in hypertension and hyperglycemia. I know, yeah, wait. So hypertension and hyperglycemia, and further 5 to 10% we can prevent diabetes. For 10 to 15% we can bring down the incidence of cardiovascular disease and MASH, and gastroesophageal reflux disease, obstructive sleep apnea, and more than 50% you can actually go for diabetes remission. So it's a very wonderful thing. That's why we have been talking since decade. I think 1933 we started talking about weight loss drugs, and that is how we have evolved. We have been using amphetamines, fenfluramine, sibutramine, orlistat, rimonabant, semaglutide, and here we are with tirzepatide and many more to come. So currently EMA approved pharmacotherapy for obesity is, let me tell you, orlistat, liraglutide, naltrexone, bupropion, semaglutide, and tirzepatide. So this I already told you that this is adiposity based chronic disease, which that's why we are trying to address it. And the treatment is in evolution, and we know that there were first generation drugs like orlistat and liraglutide, and they had a lot of problem, of many of the side effects were that, like liraglutide being good also had a lot of problem of nausea. So, and the weight loss also has been enhanced by the second generation and the third generation drugs, as you can see from the slide. Okay, and now we talk about the hormone targets in obesity. So what are these hormone targets? Actually, these are nutrition based drugs, and they are called nutrient stimulated hormone therapies. So what are the nutrients we are talking about? Nutrient stimulant, like these are glucagon like peptide, glucose, insulinotropic polypeptide, glucagon, amylin, and peptide, tyrosine, leptin, because these are all central to appetite control, and these are the all regulators on which we are trying to study, and we are trying to develop drugs against of different combinations to control obesity. What will they do? They will actually modulate satiety, energy expenditure, and glucose metabolism, and activating multiple receptors can boost weight loss outcomes. That's what we want actually. Now I will talk about current and emerging agonist therapies. That is my topic actually. So I will talk about semaglutide and orforglipron. So you know that semaglutide you already are very familiar. We have been using it is a GLP-1 agonist, and this orforglipron I haven't used. I don't know if anybody has used in the hall orforglipron. It's a new drug. It is being developed. It is also a GLP-1 agonist, and it is a novel non-peptide once daily oral GLP-1 receptor agonist for weight loss. Bioavailability is 30 to 40%. It can be taken with food, water or other medications. So it is in the phase 3 trial, so I don't think so anybody has used, and it is for diabetes as well as for obesity. Okay, and in 72 weeks they have found a significant weight loss in the obese population. Then there is another drug which is called cagrisema. It is cagrilintide. It's a tongue twisting molecules. Cagrilintide and semaglutide combination. It is a GLP-1 amylin agonist, and it is again in the phase 3 trial. So there are various regulatory approvals and broader benefits, and many of these drugs are awaiting approval. Many have got the approval. Okay. So the best drug now which we have is a dual agonist, and that is tirzepatide, dual GLP-1 and GIP agonist, and it can lead to 22.5% weight loss at 72 weeks. 78% of patients achieve more than 15% weight loss. The other molecules are there in the research, they are there in the pipeline. What are the clinical benefits beyond weight loss? As other speakers have already said, improves HbA1c, blood pressure and lipid profile. Yeah, and then now we have this triple agonist retatrutide, which is already being researched very well, and it is going to come sooner or later, and it's an excellent molecule. It is a triple agonist, GLP-1, GIP and glucagon receptor agonist. After the CME, I will ask one question. While preparing this, I thought that glucagon basically causes hyperglycemia. So how can we use glucagon agonist as a weight losing drug? Can anybody answer this? Because I got very inquisitive, because it's an agonist of glucagon. No, it is a pure glucagon inhibitor only. But the thing is that glucagon has an action which is the glucagon secreted by the pancreas. So this glucagon agonist does not do that action. It acts on all other receptors but not on the pancreas. So actually it causes weight loss by increasing the energy expenditure and by causing lipolysis, which are some of the beneficial effects of glucagon. So because I am talking about triple and quadruple agonists, so I thought I should know this. So, and then there are multiple hormone approach like GLP-1, amylin, peptide, tyrosine is PYY, and glucagon for synergistic effects. And then I already told you cagrisema, that is GLP-1 plus amylin analog. Some of these molecules have got their name. Now, a very important concern which comes to our mind whenever we are talking about GLP-1 or GIP agonist is the muscle loss. So, now we are having some drugs which can actually preserve the muscles, and for that, for that there is a new drug, bimagrumab, which has a dual action agent. Dual action in the sense it is an activin receptor blocker and apelin agonist. And please don't terrify yourself, this is all physiological thing. Myostatin, myostatin inhibitor, activin receptor blocker and apelin agonist. So many of you who know physiology very well, this way we can actually cause muscle preservation if we inhibit this myostatin and activin receptors, and if we enhance apelin. That's how you can remember. And we can counteract muscle loss. For this we have bimagrumab, which is being developed. It promotes muscle growth, it reduces fat mass and preserves lean mass during weight loss. So what is the clinical approaches? Safety, access and future directions. So obesity management mirrors chronic disease care. As I told you, adiposity is a chronic disease, and weight loss targets new guide therapy similar to...
Dr. Yasmeen, I'm sorry to interrupt, but since you have less than a minute, can I ask you to summarize and conclude?
Oh, yeah, I actually am the last slide only. What is the future direction in obesity care? You have multiple agonist therapies. You may have monoclonal antibodies and oral GLP-1 agonists and microbiome modulators, muscle preserving agents, and weight loss will remain as a biomarker for complication-centric care. Actually, whenever you are monitoring diabetes, you are monitoring sugar, HbA1c. Similarly, with such drugs, we will be monitoring the weight loss. And what is the key takeaway? Triple and quadruple agonists deliver up to 24% weight loss, simultaneous activation of GLP-1, GIP, glucagon, amylin, and tyrosine, and disease modification. And the main thing is cost. So cost and long-term safety are the two things. Next generation therapy may transform obesity care. Thank you so much. Thank you, ma'am. Any question, please?
So, are there any questions? Thank you, Dr. Yasmeen. Thank you so much. And I'm sure Dr. Yasmeen will be willing to answer your questions over tea.
Yeah, if you want, I will be also learning. Thank you.
Yes.